get started here. I think we're only going to speak for a few minutes. So this is about some of our experience, myself and Santi, using the NeVa device, which is really the only FDA-approved device for vasospasm, right, for mechanical treatment of vasospasm. I have my, the usual disclosures, more than some, less than others. So we'll start with a case, then I'll tell you a little bit about the device itself. So this is a 30-something-year-old patient that presents with a ruptured right MCA aneurysm. You can see the subarachnoid blood on the CAT scan on the right convexity. It's related to a ruptured MCA aneurysm. The patient underwent uneventful conventional coiling and did very well from all this. The patient then, on postoperative day 6, developed a progressive right-sided or left-sided weakness. There was a suspicion for vasospasm. He had a CAT scan which didn't show hemorrhage or interval hydrocephalus. His blood pressure was then augmented, and so you try to treat this medically, certainly at first. And then he was continuing to have weakness, so he was referred for endovascular treatment of his vasospasm, and you can see the MCA when he went to angiography in the red box. He has significant vasospasm involving his MCA segment, which is a common complication, obviously, of aneurysmal subarachnoid hemorrhage. So typically, the way that we would manage it at Yale would be primarily intraarterial administration of vasodilators. Our preference is verapamil, and occasionally we would use a small caliber balloon. But this device, which is intentionally designed for the management of vasospasm, was used instead. It can be delivered through an O2-1 or an O2-7 microcatheter, and you could deploy it by a standard pin and pull technique, and unsheath the device, and then recapture it at the end of the deployment. It's a one-size-fits-all, so it comes in one standard size, and it's indicated for vessels between 2 and 4 millimeters in size pre-spasm. It has much more radial force than the typical stent retriever alternatives, and so again, it's designed specifically for this purpose. There are results that were published in what's known as the VITAL study. This was a prospectively collected, core-adjudicated study that was published in JNIS, which showed phenomenal safety and efficacy results. The trial was not designed, obviously, as an efficacy trial, but there was very high procedural success and very high safety, with no interprocedural dissections or ruptures. So again, it's the first and only FDA-approved device for vasospasm. We'll point out that both Santi Center and I are both currently enrolling in the DILATE, essentially post-market registry. They're looking for new sites, so anybody that's interested in participating, just reach out to either of us or to the company itself. We'll point you in the right direction. So this here is just showing, you can sort of see that there's a lead wire to the device, and then there's a stent retriever type device that's expanded, and it goes all the way to that proximal marker. That's a catheter angiogram that's done with the NeVa device deployed, which is very nice through the O2-7 catheter, which is what I use to deliver the device. You can also infuse during the 3 minutes period of time that I left the device inflated a small amount of verapamil, so you're both treating it with a vasodilator and the mechanical effect of the NeVa device. On that middle panel, it's not so important, but you can see that the device is very easy to recapture, especially with the O2-7 catheter. So there it goes, and you have a nice result, right? So this is obviously looks much better than this. And I'm going to pass it on to Santi.
And I'm going to continue the great work that Charles has done here and try to share also a couple of cases that we've done as part of the DILATE registry. And the first case was a case in which there was a 56-year-old woman with 2 aneurysms. Both of them were enhancing with MRI wall enhancement protocol, and also the pattern was not very distinct, and we treated both. The first one we can see here with a web, and the second one was almost like a bleb-like, blister-like. Then we had to put one coil with one flow diverter and the aneurysms were secure. However, 7 days after, as it happens commonly especially in people or in patients with high-risk features, including modified feature 3 and 4s, and also more involving women and large aneurysms, we developed symptomatic vasospasm. The first symptoms that she developed were confusion and left leg weakness, and what we evaluated here is after doing a CT perfusion, we rushed into the angio suite since we had a complete hypoperfusion in the entire ACA territory bilaterally. And as you can see here in the diagnostic angiogram, we had moderate to severe vasospasm with flow limitation in the ACA-MCA territory bilaterally, although the area on the ACA where we had the flow diverter did not have a spasm before and after the flow diverter. As you can see in the picture on the left here, developed vasospasm and moderate flow limitation. Then as a result, we decided to treat, and we now move much faster, especially in young females, to go ahead and not just start with vasodilators, but go with intervention. And in this case, we use the NeVa 4 millimeter by 20 millimeter stent, and then we actually, through the once the deliverable stent was in both of the territories, the ACA and the MCA territory, one at a time. We also infused over 15-20 minutes, 20 milligrams of diluted nicardipine through the guiding catheter. And this is the result after 20-25 minutes. It's very important to emphasize that with this, like balloon angioplasty, during this time you have continuous flow going as the stent is really opening the vessel, and you have the capabilities to infuse whatever your favorite cocktail is to vasodilate the vessels. We went to the contralateral side. Even though the flow was not as limited, we still decided to treat this. We went first to the MCA in this case, and then to the ACA territory. In this case, we used the same device through the 21 microcatheter, and infused another 20 milligrams of nicardipine with great results after 15 minutes of infusion. Then that was great, and then we just, recovered the patient's symptoms resolved, but at day 13, which is a little bit unusual because vasospasm is a monophasic disease, she developed a different type of symptoms, and after ruling out all the other potential confounders, we kind of found that she was having a posterior circulation bilateral hypoperfusion on the cerebellar territory and brainstem. Then we were rushing to the angio suite, and as you can see here, we had a severe spasm in both bilateral V4 segments with a hypoperfusion on the brainstem and the cerebellar region. Sorry about that. You can see it here in the video. And we pursue. This is how the device is deployed. We leave the device over 10, 15, 20 minutes open. We unsheath with the 21, and through the intermediate or guiding catheter at the level of the V2 segment, we infuse nicardipine over 10 to 15 minutes. And this is the result on the right side. As you can see, really nice result after the treatment. And then on the left side, again, very severe spasm, left the device open for 10 minutes, infuse some nicardipine, and you can see the result here. And this is the MRI showing that we still had some stroke at the cerebellar region, but with very good clinical resolution. And in conclusion, I think that this is a tool that offers a new option to treat symptomatic vasospasm after subarachnoid hemorrhage. It delivers a consistent radial force, which I think is critical, that allows us to also institute other type of treatments, vasodilators primarily intraarterially. It remains or maintains the anterograde flow, which I think is critical. Some of the problems we had with balloon is we had sometimes a rest flow, we developed some clots, sometimes we cause dissections. In here, the radial force is consistently open over time. That's why you need to leave it for a little bit of time there. And again, allows us to use medication, vasodilators, or if you have a distal clot, even other type of medication that you might choose through the guiding catheter. If you use a 027 microcatheter, you can also infuse locally once you unsheath the stent and deliver the medication. Thank you so much.
Thank you, both of you.
I have a question.
Elias? It's safe to push and put the stent, or you need to resheet to move to change the.
No, this is a very good question. The important thing here is you have to unsheath and resheath. You don't want to pull, because remember, this endothelium and vessel is spastic. You have a lot of friction. Then it's very critical that in that technique you unsheath, deliver the medication, wait for a little bit of time, give vasodilators if you want to do that, and resheath without pulling back the stent lever. Otherwise, you can cause dissection.
Yeah, go ahead. So it seems to be quite durable. The results that were published in the prospective study showed that over 90% of the time it was like one and done, and you didn't have to go back and do an additional treatment, which is quite nice. We've had cases where that hasn't been the case, but I think in the majority of cases it is. I'll just make one final comment that what I love in particular about the device is that because there's no FDA-approved mechanical device for vasospasm, you can't do any or propose any NIH or StrokeNet or any type of government-funded trials because you're using an off-label product. So this is the first time that we now have an on-label product that can now be put into a trial in that setting because it's going to be used on indication, which I think is a major step forward for the field in doing sort of further investigations into vasospasm treatment.
Thank you very much. Thank you very much, guys.